And hello, everyone, and welcome to this talk. It's Ryan Hassan here, co-founder at the Centre for Healing. Very excited to bring this talk to you. We are speaking to Georgie Oldfield from SERPA, the founder of SERPA, actually, and I'm going to throw over to her in a minute to do a talk. We've formed a little bit of a relationship over the last few months. Quite a few of our EP practitioners are also SERPA practitioners. I myself are so interested in the topic of chronic pain. Obviously, the way that I have sort of educated and worked with clients is through the lens purely of emotional and trauma, but I'm really looking forward to hearing what Georgie has to say today. I've put all of her details and SERPA details in the description, so I won't go into detail there and take up time. But basically, we will have Georgie's talk. After that, we'll hear from some of our amazing practitioners who are both in body processing and SERPA practitioners. And also for everyone who's joining us live, we will answer any questions that you have as well. So as we go along, if there's any questions, you can either wait until the end or don't hesitate to put them in the chat. I'll monitor those and we can go over those at the end. So without further ado, thank you everyone for joining us live, and I'll throw over to you, Georgie.
Thank you, Ryan. Thank you for inviting me. Hello, everybody. Nice to actually talk about this, to see people that I recognise as well, and friends. So nice to see you. So I'm going to talk for about half an hour. I've put a few slides in that I might not be able to have time to go through, but I wanted them there so that when people are able to look through it again, you've at least got the information there. And obviously we're looking at chronic pain, but how that links with trauma, which obviously benefits you. So I want to start with just looking at the chronic pain crisis at the moment. Obviously, at the moment, I'm just looking at mainly the UK. I also want to say thank you to Irene. I've nicked some of her slides with her permission from a recent talk she gave, so I integrated those. So what there was, even back in quite recently, 2016, they reviewed in the BMJ, the British Medical Journal, found that chronic pain affects 35 to 50% of the UK population. Bear in mind, it's probably quite similar in America, Australia, and across Europe as well, but this is specific. The British Pain Society survey showed that 8 million adults report chronic pain that's moderate to severely disabling, 10 billion cost to the UK economy, and back pain accounts for 40% of the NHS. So you can see how enormous a problem this is. This is a huge problem. It might not kill us, but it's still a very expensive, debilitating, awful thing to live with. And with regards to America, the US chronic pain costs $635 billion a year, which is an incredible amount. And it's actually more than diabetes, heart disease, and cancer combined. So this is a big problem. This is not sort of something that would be nice to help, but this is actually a real problem throughout the world, in the Western world at the moment. So the main thing is that chronic pain is rarely caused by structural damage. This is an important one for all of us. And it's estimated that 1% of low back pain is due to red flag. Now, we call red flags those things that are dangerous, those things that we must be careful not to dismiss and to say, oh, yes, we can help you with that. Using an emotional focus. No, we could maybe help these people with red flags with symptoms that they have with these conditions, but we would never go in and say that the SERPA approach would resolve cancer or infection. So these are things that they need to be sure that they are covered medically and being treated for cancer, infection, fracture, autoimmune disorder, or syndrome. Now, we are aware from the adverse childhood experiences studies, for example, the link between the trauma in childhood and some of these, but we cannot go out and say we can cure you, we can help you resolve these. These are things that we have to make sure that these are ruled out before we treat something as what we call either a mind-body condition or psychophysiologic disorder. There's so many different terms, unfortunately. If we call it a mind-body condition, it's simplified. So 5% of people are found on scans to have a disc prolapse with nerve compression. So again, we would be very cautious there. But having said that, if quite often MRI scans show nerve compression, but actually they don't have the symptoms that would be relevant to that. And it might be symptoms going down the wrong leg, for example. So this is when we would start questioning what's going on. But these are things that we just need to be focused on. But of those people that do have scans, 94% have no definitive diagnosis. Okay, so these are all things where they just can't see what the actual cause of the pain is. And the trouble is, what they found is that when people have MRI scans, that the studies have shown they're more likely to have possible intervention, because then they're seeing, oh my goodness, I've got nerve compression. We'll come on to this later, but these are scary things for people. If they believe that then there's something, a problem with their back, they're more likely to have a problem, and they're more likely for specialists who are unaware of the mind-body link to then go and do surgery or an injection or something. So all tissues, even if there's been an acute trauma on the tissues, are structurally healed after 3 months. So even the big bone, the femur in the leg, it will heal after 3 months. So what we're talking about here is really chronic pain, persistent pain. And even not with focusing here pain, but often there are other conditions. Every system in the body is affected by stress and trauma. So we do treat all sorts of other symptoms of tinnitus, but we're specifically focusing on chronic pain. So when the tissues have healed, why does the pain continue? It's to do with that. So most chronic pain,
Georgie, can I stop you there for 1 second? Just your audio is just a little bit in and out. It'll be okay for a bit and then kind of drop out a little bit.
Right.
Is there maybe a hands-free headphones, or we can try that speaker that you've got again?
We could try the speaker we started with that works for Gina. I must admit, you were coming in and out when you were in this. I'm just wondering now.
Well, that's quite echoey.
Is it quite echoey? Let me try earphones. Sorry about this.
That's okay.
It wasn't a problem before we started.
That's all right. It's always the way. Absolutely fine. I can't believe that 35 to 50% of people in the UK are chronic pain. That is a wild statistic. That would be the same here in Australia.
The same in Australia as well.
Yep.
Now, how does that affect things? Can you hear me?
I can hear you okay. I don't know if are they connected?
Still an echo.
No, that's okay. Let's give that a try. So just keep going and we'll see how we go. Thanks, Georgie.
Yeah, okay. Tell me again if you want me to stop. Okay, so as I said, beliefs play an important part here. And most people with chronic pain believe that their body structures are fragile, broken, degenerating, and will never recover. Now, the problem with this is being reinforced by the biomedical model, people who are not yet aware of the biopsychosocial model or are still too focused on the bio, on the body. It doesn't help when they have the scans, because when the scans are there and then they're told, oh, you've got a broken, a crumbling spine, people can be told, or you must be careful because there's a real problem with your back or with your knee or whatever it happens to be. Then they start believing that, and then they're more cautious, they're focusing more on the pain, they're more fearful, they're using crutches, not physical crutches, but pushing special cares, and that really reinforces these pain problems. Can you hear me all right now, Brian? Yeah, okay. So one of the things that we need to do at the start of this is use education, use the research to help change these fearful and inaccurate beliefs, because it's absolutely essential for recovery. Because if you still believe that there's you're going to make things worse, for example, by bending forward, then you will struggle with that, and I'll explain this in a moment. So all pain is produced by the brain. It's not, as Descartes believed thousands of years ago, that actually there's a sensation in that pain is felt, and then there are sensory nerves that take pain to the brain. That was certainly believed for a long time, the pain gate theory, and this has been disproved now. In fact, one of the people who has been doing a lot of the studies into chronic pain is the physiotherapist and neuroscientist Lorimer Moseley, who's an Australian. And his research has evolved, especially over the last 15 years. And the recognition, we recognize not just from Lorimer's work, but many other pain scientists, that all pain is real. We're not saying it's all in the head. It might be in the brain, but it's not imagined. We can't imagine pain. We cannot create pain by imagining it. So all pain is real, and it's an output of the brain based on a summation of sensory inputs. So yes, what we feel, the sensory nerves that pass things up to the brain, that's important. But then it's about emotional inputs, fearful beliefs, memories, expectations, culturally, what our norms are. So basically, pain is a danger alarm to a threat, but the threat can be a physical one, a psychological or emotional, and I hope that will become clear in a little while. So in chronic pain, the danger alarm is sensitized. This is a primal response from the brain, and it's if there is danger perceived, then the chronic pain or another symptom can be produced, and normal inputs are interpreted dangerous by the brain, but again, it's a perception that this is dangerous. So, the little man wasn't supposed to pop up then, but never mind. So it is like an alarm, and if you think of an alarm that goes off, if we don't reset that alarm, it will just continue and continue. This is really what's happening with chronic pain. It's been triggered, but nobody's turned it off, and it becomes sensitized. It's like, for example, if you've got an alarm in the house, maybe a burglar alarm in the house, if it's a sensitive alarm, it can be set off by a spider. So the perceived threat is there's danger, but it's actually just a spider. And I will choose just a little story from when for anybody who's listened to my TED talk, I mentioned it there just very briefly, that an alarm for me, a perceived danger, or a real danger for me actually, was waking up over 30 years ago now, waking up to see a burglar at the end of my bed. Okay, so that was a major threat to me and to my husband. But actually, I had no symptoms at all at that point, and we got over it. Didn't know all the stuff that I know now. We got over it, carried on with our lives as normal. About 6 months later, my husband went out and got back later than expected, and I fell asleep in bed. That's the first time he'd left me on my own since that night. I woke up in huge fear because I heard the bedroom door go. Didn't hear him coming home, I just heard the bedroom door. So immediately I was on my tummy, I pushed up and I looked to the side and whisked my head around and just thought, oh, it's only my husband. I went back to sleep. So obviously went back to sleep with this without you metabolizing all the emotional energy, the fear that I've actually triggered. And in the morning, I couldn't lift my head up out of the bed. I had acute collars, neck sort of screws around in absolute agony. It took weeks to resolve that. So the threat in that case was emotional, but it actually triggered all the unresolved emotions from that time. So this man here, this is really about showing that pain is a message, it's not a sign of tissue damage. And if you think about it, when you break a limb, you have pain. Usually, actually, I used to say that, now I'm thinking, well, do you? Because there is no link, and I'll show that in the next couple of slides, between tissue damage and pain. And actually, my son broke his knee kite surfing, and he didn't know he'd broken it. He tried to get back on his board because there was no pain. It was only because his knee gave way that he couldn't actually continue. Ended up in hospital having surgery on his knee. He had no pain. He just thought, oh, it's my turn for a knee injury now. Thought it was a cartilage rather than a broken bone. But usually, if you have broken your bone, there's a threat there, and your attention is on your leg. The primal protection is pain, using pain to protect that. Let's say it's the leg from further damage. So really be careful with it. But when you have the plaster cast on, and I know I've had this myself as a child, within a few days things calm down and there's no pain. Now that bone doesn't heal in a few days, does it? So basically the bone is still broken, but there's no pain. So it's not a reflection on the actual tissue damage. Pain is a protection in that if you put your hand towards something hot, it makes you take your hand away. So in a hot plate, if it's as you go towards it, you will get pain before you burnt yourself to make yourself take your hand away. Same with things like, doing a hamstring stretch. For all of you, when you stretch your hamstrings or any muscle, you will have pain at the end of range. But actually, this is just protecting you. It's not damage, is it? It's not actually torn your muscles. It's protecting you from going to the point where you can. And in fact, people who can't feel pain, they're more likely to actually have them and to tear muscles or hurt themselves more, of course. But it's a message. It's not an indicator of the amount of tissue damage that it has. And let's see if this is going to work. Okay, so this is predictive coding. I'll just start that for a second. So it's used to generate predictions of sensory input that are compared to actual sensory input. So this is, for example, where it relates to chronic pain. If you believe that bending is bad for your back, you will have pain. That's a prediction. Pain will be predicted. But just have a look. This is happening in everyday life all the time. And just have a watch of this mask. So that's the front of the mask that's then turning around. You can see we're coming to the back. Then watch what happens, because it looks like you're looking at the front again. And this is our brain predicting what's happening. We don't see from our eyes, okay? We sense that things come through, and then it's our brain, it's our nerves that then predict what we feel we see. If you have never watched the video by Peter Kay, he's a UK comedian. I'm trying to remember what it's called now, but he's got a brief recording on YouTube where he's plays lyrics. So if you put Peter Kay in Google with song lyrics, he plays lyrics. You hear what you think you should hear, and it's hilarious. But he actually will tell you, and then all you can hear is what he says. So our brain is predicting things to try and protect us, to try and simplify things for us. So as we said, pain is real. It's not imaginary, but it can be inaccurate because our brains try to predict and sort of and as I said, it's not an indicator of damage. This photo was the son-in-law of a patient who actually was listening to a talk I was giving at a conference. And this is a real photo of a construction worker. And he actually somehow, I don't know whether it was with a gun or whatever, managed to get this nail in his hand. He had no pain at that time. Okay? He went to hospital, had it removed, resolved, but he actually had no pain. Exactly the same thing happened with my husband. He was cutting his hand really badly, his thumb really, really badly when he was trying. His forage harvester was causing a problem. He's in agriculture. He had no pain. His focus was not on fearing, oh dear, what have I done? His focus was actually on, oh my God, my new machine, there's something wrong with it. Nobody's going to drive it back to the farm for me. I've got to do it. And what's happened? Is it a big problem? Am I going to lose work? That was his focus rather than fear about the pain. So if you think of that summation in the brain, yes, the sensation went up, and yes, he could see that there, but he wasn't fearful of it. He just had to get it sorted to get back to work. So maybe worrying about, okay, well, I'm going to lose money if I'm not at work. So it depends on the situation as well as your previous experience. This is another image of a guy. This is back in 1995 in the British Medical Journal. And this is another construction worker who jumped down from a platform and landed on this huge nail. He was absolutely in agony, apparently. They took him to casualty. They had to cut off his boot to try and get the nail out. But before they could even do that, they had to dose him up with morphine and really heavy medication. He was in so much pain. Yet when they cut the boot off, they found that actually the nail was going through his toes. Okay, so again, for him, it was about the perception of, oh my God, that's horrendous. I've injured my foot, and probably thinking a loss of work and etc. So this is just showing there is no, whether you've got a damage to the tissues, you might have pain, you might not, but you might have pain anyway, okay? So I'm going to just have a quick look through some of the studies. So this is one done by an osteopath. He reviewed over the previous 25 years of studies looking at back pain. And he found that actually postural structural and biomechanical infections are normal variations, not a pathology. So this means, for example, that somebody might have one shoulder higher than the other, or this is the back pain, but it might be that somebody's got very poor posture, or a slipped disc, or poor core stability, and yet that's nothing to do with the amount of pain someone's in. In fact, the core stability theory that you needed to strengthen your core up was completely disproved. And in fact, probably when they looked at it, people with back pain actually have an increase in tension around their back rather than a lack of power around there. And no amount of strengthening your back will resolve pain. Okay, unless you believe it will, having said that, then the placebo effect will come in. But they show that there's no relationship between pre-existing postural structural and biomechanical factors and back. And that's a really important study for people to recognise and start breaking down this link between worry about there finding something in the spine that's what we often call as a normal abnormality. And so what we see and the pain that we have often don't fit anywhere. So if we look back at this study that was done in 2015, and they're finding that actually these are people, most people who go for scans have pain, don't they? So they go for a scan to find out what's wrong. So what they've done, and it wasn't just this study, there are loads of studies since the 1980s looking at people who don't have pain. So if you look at your age, and I generally go to 50 just because they're nice simple numbers, basically by the time somebody's 50, you will have an 80% chance of having disc degeneration. So this is basically wear and tear, arthritis in the spine, and 60% a disc bulge. Okay, now this is a really important study for people who have had a scan and are being told that they've got a prolapsed disc, or they've got degeneration or facet joint disease or whatever, because so do so many people who actually don't have pain. Okay, so this is, and more often than not, even when they've had scans, their symptoms do not match with the findings in the scans. So remember, 94% of people will have a scan, show this, and we know that it's actually perfectly normal. We start degenerating from about the age of 20, unfortunately. I'm way down the road now. And I'm quite interested to have scans just to look at what's going on in my body. But it's just like grey hairs in the spine. It is just aging, part of aging. Okay, so this is actually a scan of one of the patients I saw many, many years ago, actually, when I first started doing this work. As you can see, they found that there was a massive disc protrusion here at L5-S1, compressing both S1 nerve roots and causing marked central canal narrowing, basically. So this was both sides, and yet, interestingly, her symptoms were primarily on one side. It it caused her pain, it caused her muscle weakness. She couldn't stand up on the toes on one of her legs. She lost one of her reflexes in her ankle as well, and she was heading for surgery. And thankfully, she followed our approach, and she managed to resolve all the symptoms that she had. I think she was left with just a tiny bit of numbness down the side of one toe. But this was something like 13, 14 years ago. We're actually friends on Facebook now. She's still absolutely fine. And it was things going on in her life, and she still, those things continued to get worse. But she learned to manage them better. She dealt with any past stuff. She dealt with how she was dealing with everything, changed her mindset, etc., etc. And she resolved it. And not only regained her life, but started doing things that she hadn't done before, to do. She was very active. And obviously she's now 13, 14 years older than she was. So this is another one. I don't usually show this just because it's quite horrifying. At least with this lady's scan, it's a nice smooth spine, which it should be. But look at this one. There's a real shift. This is called a spondylolisthesis. And when this lady was in her 20s, she had back pain. And I always find it funny looking at people's faces. I saw yours there, right? It looks horrifying. But actually, she had a grade 3 spondylolisthesis in her 20s, and she had back pain. And then that's when they found out she had it. In her 30s, she found out she was pregnant. And I think it was in about her 3rd trimester, she started being worried about this because she knew that she had this spondylolisthesis and would it get worse. Although they did a scan, they found she had grade 4 spondylolisthesis, didn't have any symptoms. Okay, and this didn't get any worse. So this was part of her. And interestingly, in Eskimos, apparently 50% of them have spondylolisthesis, which they find out through the cadavers. So it's not a cause of pain. So just briefly looking at other joints rather than the back now. In professional basketball players, nearly 50% of them have cartilage lesions in the knees, and yet they're playing to a professional level. Okay, so these are people who have no pain, and they did this really just to see what is going on in their joints. So specifically with basketball players, they use their knees a lot. So they found that, yeah, loads of them had degeneration, and nearly half of them, but there was no, they had no pain and playing. Same things with hockey players. They were looking at hips, so arthritis in the hips, other pathologies in the hip and groin, 77%, and yet no pain and working professionally. And in baseball players, 40% of them with their throwing arm, the dominant shoulders, had partial, and I find this really interesting, full thickness tears, yet no pain and working and perfectly normal. So let's consider psychological factors. This is nearly 3,000 employees. I have a feeling this was an Australian study, actually. And they were tracked for 2 years, and they looked at their whole lives. What was their life like at work, at home? Were they sitting, standing, lifting, whatever? What were they actually doing? And they found that the most consistent predictors of back pain were lack of decision control, empowering leadership. These were nurses who were studied for every 6 months. And again, they looked at how much lifting and handling they did, as well as any stress going on in their lives. I bet you they didn't look at past trauma. I don't believe they did. But they looked at what was going on in their lives. Other than a history of low back pain, pre-existing psychological distress, the only factor found to have a pre-existing influence on new episodes of low back pain. So that could be exam stress or partner stress, and yet that triggered back pain. It had nothing to do with whether they were lifting patients or not. So I'll put these both down, but basically for the lumbar surgery one, with adverse childhood experiences, in patients with poor surgical outcome, the incidence of serious childhood psychological illness is 75%. In the group with no risk factors, there was only 5%. Same with the second one, that through psychological screening, they could actually predict with 82% accuracy who would have a poor diagnosis. So this is really showing that pre-surgery, there's a lot of the chronic pain in the Western world is actually post-surgery pain. And if they use something like this to be able to look at who had trauma and what the psychological profiles are, they could actually reduce the amount of post-surgery, improve the results in post-surgery. So this study was carried out with a placebo collision, and this was basically a pretend crash. They sort of built this car, they made it go forward and then bash against something, very simply. They knew that this placebo collision could not possibly cause any damage, any physical biomedical damage. And what they did was they did a psychological profile test beforehand to see if they could predict who would have pain afterwards. Bearing in mind that whiplash, chronic whiplash, is a mind-body condition. Okay? And more often than not, if you're sitting in a car and hit from behind, that's about beliefs, that is not about tissue. So 20% of subjects had whiplash symptoms, even though we know that it couldn't have caused any damage. But get this, they predicted it with 92% accuracy who would have pain 4 weeks later. Okay, so 10% continued to have pain, and they predicted who those people were with a 92% accuracy. This is nothing to do with the force of the accident, with any physical tissue damage. Okay. So I love this quote by Gabalete. Trauma is not what happens to you, what happens inside you as a result of what happened to you. Trauma is that scarring that makes you less flexible, more rigid, less feeling, and more dependent. So we're coming on to the bit I'm just going to really whiz through because this is EP stuff as well. All the different types of trauma. I'm just going to whiz past this. Don't even need to go through it. And of course, the adverse childhood experiences studies, looking at different categories of childhood trauma. And the fact that these studies show that the number of categories of adverse childhood experiences had a graded relationship to the presence of adult diseases. All the major killers in the world, but it includes chronic back pain, migraines. Okay. And obviously they were strongly interrelated. People with lots of childhood trauma have more health risk factors in later life, like drinking. So I'm not going to go into this. We know this here. So, but what I'm going to try and link now is the trauma and pain. So this study showed that stressful life events in childhood, adolescence, and in adulthood seem to be very common in fibromyalgia. And life events were experienced as more negative than the life events experienced by healthy controls. And I think that's really important again. This is about perception, this is about personality, this is, you could do a psychological profile and start looking at the personality traits we do consider with fibromyalgia as perfectionist and analytical. And then this again includes fibromyalgia. So history of childhood abuse in each group, fibromyalgia, 64.7%. So those are significant percentages. Doesn't mean that everybody who has fibromyalgia has had childhood trauma or trauma, but we have to look, we have to consider that. And if it is that, then that might be the clue to helping them resolve the symptoms. And if it's not considered, then no wonder pain persists. And this again showed that children who had experienced hospitalization, institutional care, maternal death, or familial financial hardship were more likely to be suffering from widespread pain as an adult. So again, really linking that with the pain side of it. We know that when pain when there is tissue damage, we have there's in the areas of the brain where the part of the body is, we will have activity in those areas. So when there's acute pain, at the front. When it's chronic pain, the activity is in the emotional part of the brain. So this is why it's clear we need to start looking at what is causing these neural pathways to persist. So the neural pathways become learned and sensitized. So this is one of the early slides. Thank you, Lily. So the nervous system in childhood can learn that certain emotions are dangerous and become wired with anxiety, fear pathways. This is the fixating on the pain, the fear, frustration, fighting it, trying to find a way out of it. This all creates a lot of resistance to the pain resolving. Later in life, a dangerous emotion evoked during a stressful life event in adulthood can cause physical pain if the emotion is fear of it surfacing. So the primal brain will protect us from actually feeling that emotion by triggering a physical response. And it's a reflex, basically. So a reflex belief that physical pain is safer than feeling the emotional pain. And it results in distracting us from actually what's going on in the body. So the neural circuits involved can become learned and sensitized, but they can be reprogrammed and unlearned. I think that's the important thing here. And that's where EP works so beautifully with our work, with dealing with the underlying reasons for all this. And this is neuroplasticity that we know now that the brain can change. So I'm going to whiz through because I always take longer than I think I'm going to with these things. But you'll have the slides anyway. So the triggering could be anything, and again, fits with the EP. If it's an anniversary of somebody's death, that can trigger a response, but it might not just be an emotional, behavioural, or mental response. It could actually be back pain, a migraine, or something. All of these can actually trigger a response, including a belief. If you believe that sitting too long in a chair is bad for your back, you're more likely to actually develop. And while you're stressed, if you're doing activity and you're stressed, that's more likely to trigger a response. So these are other things that are involved in why pain persists. These are various studies that show, and I've put in bold, anxiety, mood, beliefs, loss of hope, great exposure to past trauma, personality traits. Hopefully this is now, you can really see how this just so fits in with the embodied processing and how that work fits so well with ours. Because if these are what's causing the pain persisting, then we can work on these and we can help then the pain to settle down. So these are all things that create a self-perpetuation of the pain. Okay, high vigilance, the overuse of, having to take a cushion with you wherever you go, wondering whether the right chair is going to be wherever you go, or having doubts about it, what is inner turmoil. And then it's all fighting it, frustration, fear, trying to fix it. This is hard work and it's desperation. And this is about actually not working on those to resolve all those. So this is very briefly, again, these are, fear and trauma memory can become sensitized. It can actually increase pain. The medial prefrontal cortex, that's where beliefs and rumination apparently are stored, and therefore they can increase. The plus signs here show that they increase pain. The anterior cingulate cortex mediates pain, but it actually can amplify pain when it's triggered by emotions. Same with anxiety, anticipation, expectation. So what we can work on, apart from the emotional side of things, is the dorsal prefrontal cortex, front of the brain, the rational, logical part. This is the other side of things, mindfulness. But so working with this area, working on the deeper emotional side, can help with all these. So back to neuroplasticity, just to show that we can change things. Neuropathways can have been learned and sensitized for years and years and years, but they can be dormant. By working on them, they can become dormant and we develop more healthy neuropathways. These are the things that we work on in SERPA with our patients. We look at the current life stressors, the childhood traumas, if they're busy life, they're overstimulated, as well as our personality, our beliefs, and our beliefs. Again, I'm not going to talk about this because this is something that will be here on the slides for people to look back on. But we start with education, really helping people understand why their pain persists, what's the evidence base behind it, and start for them to build up their own evidence about what they can do that maybe they didn't. So having an evidence base can help, but education will focus on the emotional, obviously the EP work really well, the emotional behavioural, and we look at their lifestyle as well. So these are a couple of studies that were done in parts of the work that we use within SERPA. And they reappraised primary chronic back pain, help patients reappraise their pain as being due to non-dangerous brain activity rather than tissue damage. And the use of cognitive, somatic, and exposure-based techniques. The somatic was somatic tracking. It was less about real deep emotional work. But still, these were the results. So 66% of the pain reprocessing therapy compared with the 20% of the placebo. So that's significant. And that's just one area of the work we use, one of the therapies that we use. Okay, so this is another one done by somebody else in our field where they did use more of an emotional awareness technique. And they this one, the psychophysiologic symptom reframing, basically. So they used, it's based on back pain again, they used usual care, mindfulness-based stress reduction, and the PSRT, and they found that they were pain-free at 26 weeks, 3.6%, so similar to the other one. So this is more on the using the psychological but emotional awareness, again a bit of somatic tracking but mainly emotional awareness work. And the MBSR, the mindfulness-based stress reduction, is used for pain, and certainly in the UK NICE guidelines recommend it, and yet look at the results, only 25% were pain-free at 26 weeks. So we use mindfulness. So you add them both together and look what sort of result you could have. So conclusion, basically the evidence-based mind-body approach converges knowledge of pain science, stress physiology, psychology, trauma, and emotional factors, chronic pain doesn't need to be managed. We just need to find a way to be able to actually work through these. It can be resolved in neuroplasticity by working on the underlying causes. Recovery is dependent on the acceptance of the paradigm shift, both for the clients and healthcare professionals, moving from the biomedical model to the psychosocial and emotional model, and a willingness and readiness of the client. As I know you say, Ryan, it's about meeting people where they're at, and when they're ready, they can do really well. So this is where you can find us. I hope that was a bit of a whistle-stop tour, but I hope it covers it. Helps people see that really this emotional, this trauma work can also be used with so many other physical conditions as well, including chronic pain, to resolve it rather than just manage it. Okay, thank you.
Brilliant. Thanks so much, Georgie. That was fantastic. I've got a bunch of notes here. I'm a bit of a note taker, but a lot of the notes were kind of summed up because as you were describing pain, pain is a protective response. And I'm like, it's just talking about emotions and emotional reactivity to me. And then when you showed the brain at the end and how acute pain is felt more in the prefrontal cortex, but our chronic pain is in the emotional areas. And yeah, I think I referenced it in the training, but it's like that feeling of fierce rejection, that same area of the brain will light up as if someone was stabbing you with a knife. Pain is pain when it comes to this stuff at the end of the
Absolutely.
day. So, and also one of the causes you had there, the loss of hope about the future. And you can see how these things feed off themselves, because so many people that I've seen who have chronic pain believe because of my chronic pain, I have no hope for the future. But then that reinforces the fact that I have chronic pain. And so I'm on this roundabout here. And so it's so important that we, something that I do and I've told our practitioners to do is like, if someone has pain, have them do what they're doing, on the physical side of things, but say, hey, we want to deal with these underlying beliefs around, hey, why I'm going to have no hope of the future. Why do I believe that if I sit at a desk for 8 hours a day, I'm going to end up with back pain, like you spoke about. So I love that talk. And I was the guy with the nail through the shoe that wasn't through his foot, like that's crazy, right? Crazy. Before I get some of our EP and SERPA practitioners to talk, was also making me think, as an inspiration for this work as well been Dr. John Sarno's work?
It is, and I nearly mentioned it. I thought I haven't got time to go into that, but yes. So John Sarno was the pioneer in this work. So since the 70s, he started working with people, beginning to recognise that there's unresolved emotions that are actually triggering pain in the patients that he was seeing, and getting some fantastic results. But he was ostracised by a lot of his colleagues doing this. So I came across his work in 2007, went over to see him in America, and then came back and started developing my work here. And at the same time, some of our colleagues in America, Howard Schubiner, Dave Clark, David Hanscom, were beginning this work over there as well. And so we developed this real global community that's become stronger and stronger all the time. So very much working together and in partnership with the American lot as well.
Brilliant. Yeah, I remember reading one of his books many years ago, and I had back pain for a while, and I read his book and I'm like, oh, this makes complete sense. I'd had all the scans done, nothing's wrong, blah, 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 like definite suppressed anger and rage throughout my life. So yeah, I found his work really, really powerful for me. That started with my kind of healing stuff. It goes in themes, and that kick-started probably a couple of years of working specifically with anger and rage. And I'm safe to say, apart from a little flare up a couple of months ago, my back's been great. Just about that flare up as well. When I was in Thailand, I got really bad back to the point that I couldn't walk. And it was funny, after I got back and it started to get better, I was talking with Matt. We're always pretty much doing therapy on each other before we start recording something. And we started really going into it. And it was more so, it had this back issue. I was in Thailand. I'm weight training 4 days a week. I'm playing golf a couple of days a week. I'm training Muay Thai. I'm running around with my son all the time. And so what we found is actually, when I jumped into it, the underlying drivers was the compulsion of me needing to do something so intensely physical all the time. And there's an underlying anxiety and drive there. So it wasn't like directly linked to the pain, but it was the driver behind the pain. So it's like a level deeper. So yeah, really interesting to get to the root.
Because although Dr. Sarno talks a lot about rage, and yes, that can play a big part, there are so many other emotions, if they are not acknowledged and expressed, that can then result in physical symptoms.
Yeah, awesome. All right, well, we're nearly up on an hour, so let's hear from some of our practitioners on here. Gina, Michelle, Carol, Lorna, Melissa, and Iralee. Who would like to kick off? Who wants to go first? Gina, I'm looking at you. You're going first. So unmute yourself and maybe kick us off in this discussion around how you're, using the SERPA method and also EP in working with clients and your experience of both courses.
Yeah, sure. Thank you both. That was fantastic. I work almost exclusively actually in pain, chronic pain and other chronic conditions. And I've done lots of different training, but including training with Georgie and SERPA and also EP. And they just mesh together beautifully in my practice. I'm a psychotherapist, so it's largely sort of somatic and talk therapy is my stuff. I think the thing that really is important that SERPA adds to EP is, as Georgie said, we have to change false beliefs about pain as part of the healing process. EP is such a fantastic embodied modality, but you can do a lot of work with people and their symptoms, but if there's still sort of a biomechanical understanding of what's going on, even if they've got the understanding, the emotional connection of what's happening, it's that having to undo a lot of the conditioning that's come through trad approaches and to sometimes offer quite solid, scientific evidence to counteract all that information that's been reinforced through very well-meaning practitioners, but that's just reinforcing that pain is a big part of it. So most of the people I work with, that's where we start with some education, and then I'm using EP essentially to then work in quite an embodied way to make the links and to tease apart all the different elements that are going into that pain output. So the emotions, the memories, the sensations, the impulses, all those bits that we work with in EP, and sort of differentiating them all, and then helping to sort of relink them in a way that's healthy. So that's my experience, and I'm just a great evangelist for both modalities. So yeah, it really excites me that there are more people sitting in both camps now. It's great.
Brilliant. Thank you, Gina. Yeah, I think it's so important. Like even me then, Georgie was talking, you were showing a lot of those studies and everything. I'm like, wow, yeah, you can see a lot of, not everyone, but so many people who are in that, chronic pain state, when they start to see that information, there'll be a part of them that softens. It gets challenged, but then it kind of can start to soften. And as soon as there's cracks in that, we can kind of get in there and find out what's underneath and what it's been protecting. And especially for a lot of people who are so, analytical and scientific, as soon as they get that information, it really does shake them up a little bit in a good way, that they need. Awesome. Michelle, I'd love to hear your experience.
What Gina said, basically. I think that I was a chronic pain sufferer, which is how I got into this whole thing. And Gina really helped me with my journey. But I really needed that neuroscience bit. So I really needed that brain stuff. And I needed that, all that stuff about the spine and the disc bulges and all those things don't necessarily equate to having a dodgy back, having signed up to a lifelong of a dodgy back because dad had a dodgy back. And all those physical therapists that look at scans and tell you those things and, oh, you'll never be able to do this, you'll never be able to do that. And I'm constantly just having to, that's a really big bit, that whole bit around that we've been led to believe structural things cause pain, like really that's a massive thing to undo. And then that education about how you can actually change your relationship to the pain through the neuroscience and through the brain rewiring that's just a really important part for me, because I think you can process until the cows come home, but you can still miss that bit of information. And it's that bit of information that I think is really critical for someone that's, especially if they're suffering from that real, like, I've just been working with someone with sciatica, and I mean, she was just signed up to a life of misery, and she's better now. So, it took a lot to sort of undo all of that belief, but it's that, the both of the things. And then you can't, work, same with what Gina said, you can't work with someone and then not do looking at the trauma and all the underlying stuff from childhood and from current life stresses. Like both things, I can't imagine doing one with the other. They're just very, very complementary.
Brilliant. Thank you. Yeah, the structural stuff, when you showed that, the image of that pregnant lady's spine, that's what, when I'd be in back pain, I remember I went for my first MRI back in my early 20s. And when I got the results, I expected it to look like that because that's how much pain I was in. And then I got it back, like, it looks pretty all right to me. I'm like, fuck, surely it looks like that. That's what it felt like, right? Really interesting. Awesome. Thanks, Michelle. Carol, I'll throw over to you.
Okay, hi everybody. I don't think I can really add much more other than Gina, I'm a psychotherapist too, and I really find EP helpful in the initial instance with the resourcing, because patients are highly anxious and it can take sometimes 4 or 5 sessions for them to kind of reconnect to themselves, and I found that very helpful to finding a way for them to resource themselves, and that gives them then a bit of confidence that things can be different, along with the educational stuff from SERPA as well. And then I bring in things like beliefs, fears, doubts, all those sorts of things, personality types. So yeah, it really blends itself really well, particularly the trauma. People don't consider they've been traumatized. I've had recently a gentleman in his 80s, didn't think he'd been traumatized, but he'd been brought up in the war, and he hadn't even considered that, you know, his father was killed in the war, all the stresses around that with his family, his mum, you know, being sent away at the age of 4 or something like that to somewhere else. And things started, it was kind of like a domino effect, slot into place, and actually being able to connect to himself, because he was brought up with a stiff British upper lip, you know, and he was finally able to cry and grieve some of that stuff that went on. And it was just amazing.
That's so beautiful. Yeah, as soon as you're listing those things, I'm like, trauma. But he's
Yeah.
like, no, I haven't been through too much. A pretty simple life. Nothing too wrong. Great. Thank you so much for that, Carol. Lorna, I'll throw over to you now.
So I just want to thank Gina for getting me into EP in the first place. It was Gina's little nudge and encouragement that got me here. I just think it's amazing. And as well with, along with the other SERPA tools that we use, I very much try to use EP as my sort of go-to. And it really helps get people out of their head. You could spend a whole session them just talking away, and it just gets to the root of things really quickly, without that added cognitive stuff. Sometimes we use their symptom as a trigger, if that's what they want, which has always been very interesting. Sometimes the trigger is something completely different. But it's interesting how often the symptoms that they came to see me in the first place are the symptoms that show up when you invite a trigger in. And it is fascinating how, I had a lady with hip pain. So I think we use hip pain as a trigger on that particular occurrence, went on this whole journey, as you do. And then she said, it's my fault. And I said, what was your fault? And she said, oh, my parents got divorced. And she was about age 2. And I spoke to her a couple of weeks later and the hip pain completely went. So it's just fascinating. It seems to be dealing with symptoms a lot quicker. I also, journaling is one of the SERPA tools that we use, therapeutic journaling, which is really powerful. And I encourage people to journal after an EP session to get it down on paper. And it's interesting for some people, it's kind of the process continues. The emotions have started to rise up, and then in their own time, in their own space, these emotions continue to be there and they can process. And I've had some fantastic stories with people as they've kind of continued to work through this stuff in their own time, in their own way through using journaling. I could say a lot more, but I'll leave it for somebody else.
Thank you, Lorna. That's amazing. That client with their hip pain, that's just bringing that to awareness and realizing that it wasn't my fault. Like, I'm a 2-year-old. Come on, but that's what we do, right? Everything happens because of us at that age. We're quite narcissistic when we're kids. Can't help it. Melissa, I'll hear from you now with your fantastic microphone.
Hi, I've got my earphones in. That's why I'm so loud. Is that okay? I was just thinking, I started off as a nurse and I'm a psychotherapist, and I worked on a heart ward, a cardiac ward. And I'd noticed that the men who came in and had heart attacks would often end up crying for a week or having huge emotional responses. So I'm sort of seeing the link. I was always really excited by that, where other people were horrified. I kind of always knew it was a key to part of their healing. So that's kind of all I wanted to say.
Oh, that's really interesting. Yeah, I wonder if that's just the final meeting their mortality and letting the walls down finally, and decades of emotion starting to come out.
Yeah.
Really interesting. Yeah, thank you so much for sharing that, Melissa. And Iralee, I'll throw over to you.
Hi, thank you, Georgie and Ryan. And yes, thank you to Lorna for guiding me towards EP. I'd been interested in somatic experiencing and was horrified by the cost and time it took to do that type of training. And having read about Peter Levine and understanding that this trauma work was something additional I needed to know more about with the clients I was seeing in pain as a physio, led me to EP, and I've been delighted to learn it and recently get my certificate, which is on my wall. Thank you very much. And but yes, I think with SERPA, it teaches you've got the neuroscience, you've got the impact of stress and how it affects past stress, current stress, and that piece. And then I find with the EP, it extends the somatic tracking and the emotional awareness work that we've learned through the SERPA techniques into that inquiry of origins, beliefs, linking past things, finding all this information under the symptom. It's just all there. And when you ask the right thing and guide them, and I find what's so wonderful about EP, it takes the pressure off the therapist to work out what's going on, because the person finds out what's going on through that process. And you may have an idea about what you think, and often you might be surprised, you might be completely, in the wrong ballpark altogether. And
You got muted, Iralee.
Did you not read my lips?
Sorry, that was my fault, Iralee. I'm so sorry. I was loving what you're saying. That was my fault. Please keep going.
That's what we think of you, Iralee.
I thought I unmuted myself.
No, it was just the last 20 seconds or so. It was my fault. So we heard the rest. We heard the rest.
Oh, okay, that's all right. Yeah. What can I say? It's great. I don't know what you didn't hear.
I love what you said about, it takes the pressure off, and the client will start to unpack those roots. And I genuinely feel that in a session so much. I'm like, they're going to reveal the answers to me. It's going to be fantastic. And it's great to be able to track those things. I think you said, Georgie, it might have been fibromyalgia, perfectionism, that trait, is very high in people that struggle with that. And what is perfectionism? Perfectionism is a trauma response. And we get to sort of welcome in that perfectionist part, if we can start to track its roots. Why did it have to adapt that way and be perfect all the time, but make sure it doesn't let anyone down? And you can feel the pressure behind that. No wonder the body starts to, tense up when I have to be like that, 24 hours a day. So beautiful. Gina.
Yeah, just wanted to stick one more thing in there around the, people in this sort of mind-body camp often get fixated on what's sort of the root cause, and there's the sort of Sarno's idea about repressed rage particularly. I guess in my experience, what I notice is that there's always just some internal conflict or a internal polarization, and that can be, that's usually with something that's exiled, and then those sort of managing traits sitting over the top, and so teasing those apart with EP is just a really fantastic thing. And I want to put a plug in for EP level 2 as well, because that goes more into some of the parts work and some really good depth questions around teasing out parts. So I'm enjoying working my way through that at the moment. And
yeah, I'm really excited about hearing more people's experience when the practice sessions start with level 2, because we really dive into different traits and archetypes, like the perfectionist or whatever it is. It's really important what you said, Gina, as well, is we don't want to, as practitioners and also with our clients, get them stuck in kind of what Georgie was talking about in the Western model, in that, hey, I have pain and now we're going to go and, you know, if I've got a hammer, I'm going to try and find a nail. I don't want to say, okay, well, you got a slight imbalance here and here, and that's causing the pain. And we end up always trying to search for something that might be an issue, and that can happen psychologically and emotionally as well. So I like the way that you really simply put that as this internal conflict, and normally a tender part being protected by a more protective part. Let's just look at it in those simple ways and see if we can get in touch with that tender part and give them what they need at the end of the day, and then check in and manage how those symptoms, be it chronic pain or life issues, emotional issues, are going, and go from there. So really well put. Great. All right. 5 past the hour. I think we'll wrap it up there. I really appreciate everyone jumping on tonight or this morning, depending on where you are. I really appreciate you, Georgie, in this relationship that we're forming with EP and SERPA. It's happened really organically, like super organically. And
well, it started with Gina, then Lorna, and you can't ignore it when people start talking about this, and that's why I signed up, but then you connected with me. But yes, I think it's the best thing, really, that our work, over the last few years, we've begun to do more emotional awareness, more somatic tracking. And so this is just beautiful, organic way it's just sort of merges together.
Great. And the easiest way to get in touch with you, Georgie, is it the website?
Probably the SERPA website, yes.
SERPA.org?
SERPA.org, S for sugar, IREA.org. And yes, you can get through me from there, or Georgie at SERPA.org.
Brilliant. Yep. Brilliant. Okay. Thank you so much, everyone. If you're watching the replay of this, don't hesitate to put any questions or comments down below, and we will get back to them. And have a beautiful night or beautiful day, everyone.
Thanks very much for the opportunity, Ryan.
Bye-bye.
Bye.